All right, now, aha! Now will someone on the panel talk? Where'd the panelists go? Can anyone hear Rosie now?
I can, but
you're on my phone. All right, that's good. But now we don't have panelists. Where our panelists go?
I don't know. And I can't get in the room.
Okay. This is ridiculous. Hold on. I'll be right back again, folks. There we go.
Yay.
Now we're back up.
All right. I see and hear people. That's great.
I see thumbs up. Yes. Wonderful.
You can tell we're all not technology geniuses around here, but we're getting there. So I'm Judy Zink. I'm with the Coalition for Access to Healthcare. It's our legislative group for South Carolina. We've been in business now since 2012. We were the group that got the bill passed in 2018, which at the time we knew was going to be a stepping stone to full practice authority for us. So right now we do have a full practice authority bill in both the House and the Senate. It has not come up to a hearing yet in either of the subcommittees. So we wanted to invite everybody to hear about the bills and hear what we can do to push this over the hill, so to speak. I think TK is
I can do introductions. I just can't be seen right now. Good evening,
great.
Everyone. I'm Tashika Curtis Pugh, TK, Executive Director of the South Carolina Nurses Association. We are so excited to have you all on to talk about this important topic this evening. Most importantly, we want you to take this information that you get tonight and pass it on to others. Make sure that whatever you learn tonight, that you talk to other nurse practitioners, certified nurse midwives, the clinical nurse specialists, everybody who is an APRN, and make sure they know how important this bill is and how important it is to be engaged. And lastly, I'll just say, please continue to stay connected and engaged with the association and with the coalition, because there's great work being done and we can't do it without you. So thank you so much for being here this evening, everyone.
Thanks, TK. Jada, would you like to say a few words also?
Good evening, everyone. I'm Dr. Jada Quinn, President of the South Carolina Nurses Association. We're so excited to be here and welcome you here in concert with the Coalition for Access to Healthcare. Today's webinar is about empowering you as frontline professionals and advocates to understand the key legislative issues that we face as APRNs in South Carolina and how your voice can make a real difference. The policies being shaped right now will define the next generation of healthcare. And please remember, this session is not just about information, it's about inspiration and action. When nurses speak up, lawmakers listen. Thank you for being here. Thank you for all that you do. And thank you for choosing to lead beyond the clinical setting. Let's get to work.
Thanks, Jada. So I'd like to get started on our agenda for tonight. The first part of it will be a review of the summary for our bill, the House Bill 45 and 3580. So that will be Deb Hopla and Kelly Boudelet.
Yeah, so thank you very much, Judy. I appreciate it. I'm Dr. Deborah Hopla, and I see a bunch of my friends on this. So I'm glad to see Sarah Norris and Shelby Riles, and I'm so happy to see everybody tonight. We want to cover Senate Bill 45 and House Bill 3580. And we want to talk about them because these bills are mirror images of each other. And it is to define in Article 1, Chapter 33, Title 40 of the South Carolina Code, for amendments, and those amendments will be for full practice authority. In the nuances, you can read the bills. We put the links up so that you can actually have access to them. I would encourage you to print them out and to highlight the things that are different. So this time, when we are approaching our testimonies, one of the things that we were met with was safety issues. And of course, we know that is not really an issue. But one of the compromises we made was to have all APRNs, after obtaining a master's or doctoral degree, to agree to 2,000 hours of clinical with practice agreements with a physician. And then after those 2,000 hours, the APRN would make sure that they possess their own malpractice insurance to attest to that item to the Board of Nursing and provide the documentation and receive the authorization from the Board of Nursing for full practice authority. And when we talk about full practice authority, we actually defined it as authority granted by the Board of Nursing to an APRN pursuant to the section as an independent person, specified medical acts and non-medical acts without a practice agreement. And in this data, it goes on to define things in different sections of the bill about the required education, being a master's or doctoral degree and being nationally certified. And it covers not only nurse practitioners, but certified nurse midwives and clinical nurse specialists. And making sure that when you're looking at this, one of the things that is important in this information are the nuances of being able to prescribe medications and treatments and modalities and all the things that we've worked hard for over the years, being able to sign for homebound, being able to sign for people to go into hospice and palliative care, sign death certificates. All those things are covered, but you won't have to be covered under a practice agreement. And we're going to cover later on why that is important. We all know that during COVID, we got expanded authority. And guess what? It went extremely well. So in looking at this, making sure for medications, one of the things about medications is that you can, with full practice authority, prescribe Schedule 3 through 5 controlled substances, and you are able to do non-narcotic Schedule 2s. Schedule 2 narcotic substances, under the current law for the government, Section 4453-300, you cannot exceed a 5-day supply. However, you can write for a 30-day supply if the prescription is written by an authorized provider for a patient in chronic pain management, under hospice or palliative care, or long-term care facilities. So again, full practice authority removes some regulations that are barriers for people. I want to make sure that people understand that you have to still on the prescription have your numbers and be sure to include the medication and refills that you're going to be having so that you don't stand in violation of this rule. You will have to continue getting the 20 hours for prescriptive authority, continue to get 20 hours of continuing education with 2 hours in controlled substances, and that you can do telehealth and telemedicine. Under the current law, you have to follow HIPAA regulations and high-tech regulations. And you should not be doing telehealth for any kind of visit that would require an in-person visit. And I'm going to turn the time over to Dr. Bouthillet.
Thank you, Debbie, or Deb. I want to just add some details that kind of dovetail off of what Dr. Hopla just stated. The most probably poignant change between full practice authority and not having full practice authority is the 2,000 additional hours that are required for the advanced practice nurse for nurse practitioners, certified nurse midwives, or clinical nurse specialists. And in addition to that would be having your own malpractice insurance and meeting the requirements of the State Board of Nursing. And there is a lot of onus on the advanced practice nurse to make sure that you comply with all the regulations. It isn't just, oh, I've already had my 2,000 hours. I am an advanced practice nurse with full practice authority. You have to do your due diligence. You have to complete some additional paperwork and make sure that you complete an application and that they approve you for full practice authority. And it is written in detail into the bill, and we encourage you to review it and be able to speak to it. I did post while Dr. Hopla was speaking the two House bills, or to the two bill links, so that you can read it, but it requires the APRN to make sure each step is completed. It's attestation, it is making sure you have proof of malpractice insurance, it has proof of your employment, it has proof that you've completed those hours and that you are providing care in the underserved or rural population, that you're providing that primary care. It is very important that you meet all of those criteria, all of those steps, and that you wait for the board to say, yes, you've been granted full practice authority. So we don't want anybody jumping the gun once this has been passed, that because you could get yourself in a lot of legal trouble. As Dr. Hopla had mentioned, regarding the prescriptive authority, nothing really changes there. We're all required to have that initial 45 hours of pharmacotherapeutics, and then the requirement does not change for the ongoing continuing education credits, and then the other controlled substance requirements also remain the same. The other piece that I wanted to highlight was regarding some of the specifics for delegation to certified medical assistants. If you will recall that actually was something that passed, but that again is built into this bill. It would also give us, grant us authority to commit a patient to a psychiatric facility for nurse practitioners or clinical nurse specialists if they determine that the patient is a danger to themselves or others, admitting privileges in collaboration with the physician within acute care facility or for a certified nurse midwife to a birthing center that is licensed. There are some other nuances for specialized skills where a nurse practitioner has already obtained the additional education, like ionized fluoroscopy. This seems so remedial and so inane, but it is put in there because currently writing for incontinence supplies and those necessary items require us to make sure that we can get these skills or these supplies, and signing forms that we've been doing so many other times. The tuberculosis forms, those types of forms and documentation that were required and need to do, but cause unnecessarily these delays and just time constraints that really inconvenience our patients. Those types of things are also added to this bill. I can't think of anything else, but again, Dr. Hopla and I really encourage you to do a deep dive into the language because it is very nuanced and it really delineates between full practice authority, that APRN that has those 2,000 hours of experience beyond the graduate education versus that new graduate that requires that practice agreement. Dr. Hopla, is there anything else that maybe I have missed or that you might remember?
No, I think you did a great job. And again, when people look at the bills, they are mirror images. So if you look at one, you're going to look at the other one. It's not going to require a lot of your time, but highlight those issues that the Board of Nursing has recommended that we have in this bill, that the coalition has taken all of the comments over the years and tweak this so that we can definitely make it a user-friendly bill and something that removes those regulations, improves healthcare outcomes, and saves money. And again, those regulations are not necessary, as we were able to prove during COVID.
And I would just add one last comment to build off of what Dr. Hopla just said. We are removing unnecessary regulations and barriers that cause unnecessary delays in care to provide that get in the way of us providing care to patients. But we're not asking to do anything that we're not already educated and licensed to do. We are removing restrictions, we're removing regulations. We're not trying to do brain surgery. We're not trying to, do things that we're not doing now.
Thanks,
I think our
Kelly
10
and
minutes
Deborah.
is up.
Thanks, Kelly and Debbie. TK, you and Wander are up next. Are you at home yet? Well, sounds like we got crickets.
I'm going to ask that y'all skip me and I'll come back. Wanda will not be able to be on the call today. She just sent me something, so I just want to take 2 seconds and look at what she sent me as well before I present that. So if you guys will skip me and come back to me, I would appreciate it.
That's great. We'll do that. Our next little topic is going over some of the paperwork that the Coalition and South Carolina Nurses Association have developed. So Stephanie Burgess and Kelly Bouthole will present these.
Judy, I think our next one is the full practice authority bills with certified nurse midwives at the top with Sharon and Leslie.
I must be using a different
Yes.
one.
I sent the agenda. So the next one is a review of data to support the FPA bills, and Sharon Bond
Oh, okay.
and Leslie are up first.
Oh,
Yeah.
okay.
Sorry.
Leslie and Sharon, thanks.
Sure. Well, thank you all who are on the webinar for giving up your time in the evening to participate in this. So many of you who are nurses know that historically certified nurse midwives and nurse practitioners and clinical nurse specialists all fall under the same Practice Act by the Board of Nursing. And we go back literally decades in working together to improve the status of our practice, which ultimately helps us improve patient care in South Carolina. But so for those of you who are nurses in the audience, you probably are aware that South Carolina has a serious maternity crisis. Our rates of maternal deaths are very high. The March of Dimes, which is a leading organization in women's health and newborn health, has given South Carolina a grade of F because of our very poor statistics. In South Carolina, we have only about 80 nurse midwives in the state. And among these 80, several are not practicing for a few reasons. One, they can't find a supportive physician, and all APRNs know that a physician's name must be on our license in order for us to even practice or call ourselves a nurse practitioner, a certified nurse midwife, a clinical nurse specialist. So finding supportive MDs has been a long-term issue. We also have had problems gaining hospital privileges, which really interferes with our ability to provide the type of care that midwives provide. It's probably no surprise that the rural areas have the most serious health problems for women and their families. They lack providers, they lack transportation, and that really impedes their ability to get good care. There is some good news, however. I hope by now many of you are aware that the University of South Carolina has been approved for a nurse midwifery education program that will start, enrolling students in the fall of this year. I urge you to go to the website at the University of South Carolina College of Nursing to seek more information about the midwifery education program. There are 3 different pathways to get your certification in nurse midwifery. We need nurse midwives in our state. and we are working hard to improve our practice regulations so we can get there and do the job that we need to do. Another good thing is the federal government has awarded $17 million in a grant called Transforming Maternal Health in South Carolina. And this grant is based on the midwifery model of care. It's focused on whole person care, improving the workforce and quality health initiatives as it pertains to pregnancy, and increasing access to certified nurse midwives and doulas to improve outcomes for mothers in South Carolina. And the midwifery model of care has been shown to improve the outcomes for women and their babies, no matter which type of setting nurse midwives work. And we work in acute care hospitals, in outpatient clinics, birth centers, and also home births as well. So I'll move to Leslie and let her give some conversation to what this FPA bill will mean for nurse midwifery in South Carolina.
Hi, thank you everyone for joining. I've noticed a few midwives on the participant list. That's always great to see. So certified nurse midwives practice is quite different from an obstetrician's practice. Whereas obstetricians don't take care of newborns, they don't provide breastfeeding support, they don't provide labor support, nutrition support. There's lots of pieces of what we do that the obstetrician model does not do. We also take care of our patients throughout the lifetime. We can take care of newborns, we can take care of young girls with GYN needs all the way up through menopause. So we provide primary care, women's health, as well as pregnancy and breastfeeding and family planning. As Sharon said, the whole country's in a crisis when it comes to obstetrics, and of course the South is at the worst, and we know the states with the fewer midwives also have the worst outcomes. We've had many studies done over the last 5 to 10 years that have shown that the midwife model of care not only improves outcomes, but does so at a cost savings to the healthcare system. So that has finally gotten some attention from the organizations that deal with pregnancy and women's health, as well as legislators. We rarely have to explain who we are and what we do anymore. People now understand who a midwife is, and the community support and the community demand for our services is growing. However, as APRNs, and we are under that umbrella as APRNs, we are the lowest paid. We work the highest number of hours in a week, and we have the highest cost of providing care and medical malpractice. So why would you want to be a nurse midwife? To work harder for less money. It's the passion for the model of care that leads these people, both women and men, to want to provide care. The number one reason that we see for nurse midwives leaving practice is, this isn't what I signed up for. This isn't what I went to school for. It's the lack of being able to provide that model of care that they went to school and learned to do. They are many times used as physician extenders. There are midwives in this state that the only job is to call lab results back to patients, which is a completely misuse of their training and education. I'm the previous owner of Charleston Birthplace, which was the only accredited certified nurse midwife birth center in the state of South Carolina. I've recently sold it. I've retired clinically. I still work consulting and doing political action work. This bill, a piece of this bill that the midwives are really wanting to stand hard on, is we need some language in this bill that refers to hospital privileging. Without hospital privileging, we will not see midwives grow in this state. That is where the majority of babies are born, is in the hospital, and that's where the majority of babies will continue to be born. Something that's very dear to my heart is a model called the Alongside Midwifery Unit. For short, it's called an AMU. It's very popular in the UK and other countries that have similar demographics to the United States, yet much better maternity. And that is a separate unit from labor and delivery. It's run by nurse midwives. a low-risk, healthy mother who does not want all the interventions to be giving birth and labor and delivery unit that is an intensive care unit, monitored beds, titrated drips, 2-to-1 care. So we want to see this AMU unit start to grow in our country. There's interest in it growing, but it's not a place for physicians to work. It is a place the midwives are going to work. So if you do not give midwives their own privileging, you're not going to be able to see this type of growth. You also cannot track how the care that's being provided by the midwives. The birth certificates will have the physician's names on it. It will be billed under the physician, even though legally they shouldn't be doing it that way. But the hospital, the people that are billing the facility, all they see is who the patient is admitted under. So it's very important that we have that in there. And what we're asking is that the language would say that a hospital cannot ask for a written physician agreement to grant privileges to a nurse midwife that is beyond what the law says. If you are a nurse midwife with greater than your 2,000 hours and you meet all the other stipulants in the law, that they cannot also then add that extra layer of requiring the physician agreement, so that we would be able to attract more midwives and be able to grow that midwife model of care that we know will help improve outcomes and help save cost. Judy, back to you.
Leslie, thank you, Sharon. Next up will be Stephanie Burgess and Deb Hopler to talk about the FPA bill for nurse practitioners.
Thank you, everybody, and happy Nurses Day, everybody. Just wanted to let y'all know that. Happy Nurses. Thank you for being with us tonight. Really appreciate your time. We know that y'all are busy and y'all are probably like us, frustrated. We just want this bill to pass so we can do our job and take care of patients. Deb, do you want me to go first or do you want to go?
Yeah, you can go ahead.
Okay, so just some quick data. If you look at the research overall, I mean, it overwhelmingly shows, whether the research was done by nurse practitioners, public health officials, legislators, commissioned it, whoever, and a recent article came out in JAMA. Deb can talk about that, but it overwhelmingly shows that nurse practitioners provide safe care, we provide high quality care, we improve patient outcomes, especially when it is primary care and chronic disease management. And we are a decreased cost to the system because we keep people out of the emergency room. The average ER visit in this state is around $1,100, and that's just to walk in the door and create a chart. That doesn't include labs and diagnostics and all that stuff. IVs, medication, whatnot. So to have somebody go to the emergency room for a primary care visit is costing taxpayers to the tune of about $150 million annually. And if Deb and I looked at the Medicaid data a while back, and it showed that the 15 top reasons that Medicaid beneficiaries went to the emergency room was for primary care complaints. So just quickly, we have about 9,000 nurse practitioners in the state who are licensed. 70% of those are FNPs providing primary care. 50% are working with rural or underserved populations in urban areas. The AHEC workforce data shows that nurse practitioners are the one maintaining primary care in this state, not the primary care physicians, it's the nurse practitioners. And if you look at the disciplinary data by the Board of Nursing, was it less than 0.001% of APRNs, and that includes nurse practitioners, nurse midwives, and clin specs, were disciplined for exceeding their scope or diversion, things like that during COVID, as well as currently less than 0.001%. So it's not like we're out there pill popping, shoving pills down people's throats, doing bad things. We are really maintaining ethical practice, and we are maintaining legal practice. We are adhering to the scope. Even when the governor relaxed the laws, we are still doing a great job. So Deb, I'm going to let you.
Yeah, and
Barbara.
so I wanted to let everybody know there was a recent article that came out, and I attended a webinar where JAMA, the kind of the voice for MDs, JAMA Network Open Access had an article, a research article, Socioeconomic Characteristics of Communities with Primary Care Practices with Nurse Practitioners. Yes. And the wonderful thing about this is it confirms that nurse practitioners are going into primary care. And not only are they going into primary care, but they're providing the bulk of primary care everywhere except the Mid-Atlantic area. And it's particularly here in the South, as Stephanie pointed out, over 70%, according to the workforce data book, 70% are providing primary care in rural and underserved areas. And this confirms, and it actually has the South as 83% of nurse practitioners are doing primary care in rural and underserved, those that are most needed, most needy, and the people that are in most need of good primary care providers is being provided by nurse practitioners. In every state where full practice authority has passed, no one's ever gone backwards. The VA has never gone backwards. And during COVID, when things were relaxed, again, the numbers, Stephanie and I pulled numbers for several weekends from 1976, y'all, till 2023, and 0.01% of people. It's just a minuscule number. One of the
That were disciplined
yes.
by the Board of Nursing.
Yes, by the Board of Nursing. When you try to find out how many MDs had been disciplined during that same time period, you can't get that information at all. But I would assume that it's much higher, having heard from some physician colleagues of mine that are at the State House. One of the things that we have seen a trend through the Board of Nursing, they don't differentiate between certified nurse midwives or NPs, but there's a trend upward of NPs that are leaving our state, and they're leaving our state for places where they have full practice authority. And, you know, that is a terrible thing because 46 or parts of 46 out of all 46 counties in South Carolina are medically underserved and in need. And we need NPs to be able to have these unnecessary regulations removed and improved health care and decrease cost in South Carolina for primary care.
And by the way, we also, in those 46 counties, we know that there are anywhere kind of fluctuates between 12 and 15 counties that have no prenatal care provider whatsoever and have not had prenatal providers for years.
And 17 counties have no psychiatrist. I think it's 12 counties or 14 have no pediatricians, and less than 20, or is it 21 counties have less than, or they have only 2 primary care physicians who are aging out. So the workforce data clearly shows that there are significant gaps in physician care in those arenas, in those counties in this state.
Yep.
All right, TK said she's stationary now, so she's going to talk about the workforce data.
Hello, everyone, and I'm going to try to come off camera as well, come on to camera as well, and I apologize again that I was not stationary to start, but such is life when you are a toddler mom. Are you all able to see me now? Hopefully you are.
Yes.
Yeah, we can see you, TK.
Okay, fantastic. So I'm just going to go through a couple of things. The first one is the data that I'm sharing with you all is from our Department of Public Health along with AHEC, and the data goes from 2023 to 24. Of course, we are usually a year behind as we aggregate data, but I want to make sure you kind of have a picture of where we are overall. The first thing is the state of health of nursing. So in certain surveys, in recent surveys, 60% of nurses say they still love being a nurse. 62% said that they are concerned about the future of nursing, and 39% of those say that they're dissatisfied. There are salary concerns, of course. 55% of them say that they have had an increase in the past year. 75% of nurses feel that they are underpaid. We already know that NPs are underpaid. Just by the structure in which we have CMS guidelines, we know that NPs are underpaid for the work that they're doing. And it shows in satisfaction. And in South Carolina, of course, we have even more disparities in that space. Quickly, I wanted to share with you all the states that are looking at the shortages, because one of the things that is happening, some of these states that have shortages are really trying to find innovative ways to attract nurse practitioners to come to their states. Of course, full practice authority is the number one way that they're attracting them to come to their states. But number one is California, number two is Texas, three is New Jersey, and South Carolina ranks number 4. And yet we are the state that does not have full practice authority. So when we think about how do we attract nurses to our state and why people want to come and work here, we always say, you know, nothing can be finer than to be in Carolina, but nothing can be finer than to live somewhere where you can actually work at the full extent of your education and your licensure. So it's really important to make sure that we don't lose nurses in our state. So things like the Certified Nurse Midwifery Program and other initiatives to get people to come here and stay here are vital right now for us in our state. We have 69,000 active RNs in our state. That doesn't mean they're all working. They just have an active license. We have 10,500 LPNs in our state. We have 5,800 advanced practice nurses in our state and 1,200 CRNAs in our state. If we think about health disparities in South Carolina and we think about who fills those gaps, you've heard it several times here this evening, is nurse practitioners. But if nurse practitioners at 5,800 are in our state, if we're not attracting more to come and we're not keeping the ones who are here, that number is going to get lower and lower, and it's going to happen a lot faster. So some of the current workforce initiatives, of course, I talked about the Certified Nurse Midwifery Program. Another initiative that's happening right now is the South Carolina BOLD program, which is designed to help people go back to school to get either their master's degrees and or doctoral degrees. And the caveat to that is that you're willing to work in an educational setting for at least 2 years. You can do that even part-time, but it will pay for 90% or more of your tuition. When we think about nurse practitioners, sometimes nurse practitioners are struggling with just school debt. This will allow you to think about being able to get rid of that school debt, or those who are becoming NPs won't have to have that debt from the beginning. Of course, the educational pipeline in our state is growing. We've had major growth since 2010 with continued growth with our RN and NP programs. But one of the challenges that we're seeing in South Carolina right now is that we have a lot of programs that are outside of the state. And the rebuttal of the medical association is, well, these aren't brick and mortar schools that come from our state. So now we don't know if those programs are valid or if they have the same level of education as, say, a University of South Carolina or Francis Marion or Clemson. What we have to do is make sure that as we get this bill done, that there is understanding of what is expected of a nurse practitioner, so that they know that this is not something that you can play tit for tat with based on whatever educational school you decide to go to. The other thing I want to mention is some things from Wanda really quickly, and she wanted to make sure everyone was aware that we expect to have hearings on our bill during the off session. And for those of you who are not familiar with what session looks like, we are in the last days of session, meaning session ends on Thursday. Right now, they're going to be there probably until about midnight tonight. The House budget is still up in the air. So they'll probably be there till about midnight tonight working on budgets and some other things. But the session ends on Thursday. They will have that summer and fall off, which gives us an opportunity to have discussions during that time. The plan right now is that we will have those discussions and hearings over the summer to make sure that we have a strong case for getting this bill passed. In addition to that, she wanted to make sure that there have been comments made from the Senate floor that there will be discussions next session about scope of practice and healthcare workforce crisis. So they understand and they're hearing us, but we need to make sure we keep their feet to the fire. So as we finish this webinar this evening, the big thing and the big takeaway is you can't just sit here and listen to this today. You have to be actively engaged in this process from now until we get this bill done. So we need to make sure that we have every nurse practitioner available, willing to have the conversations and having the right things to say, which is what you'll get while we continue to talk this evening. Another thing she did want me to mention, although this is not solely NP related, it is related to the work that we're doing, and a lot of the lawmakers are kind of pulling two and two together, is the workplace violence bill, which is sitting in the Senate calendar right now. There's a current objection to it, and the objection is because the senator who's objecting to it wants to get a hate crimes bill done, and because his idea about the hate crimes bill is more, in his opinion, more important than getting the workplace violence bill passed. He's digging his feet in and causing us to have a lot of challenges with this bill. So if the objection is removed, if the objection is not removed, that means it won't get a second reading tomorrow. So it will remain on the calendar and it'll come back in January. If for some reason it is removed, we could get a second reading on that as early as tomorrow, a third reading on Thursday, which means we could be ready for this, ready to go at the top of the session. So just know that that is, although not directly nurse practitioner related, what the lawmakers are seeing, they're coupling these bills together as far as how they see us. So you need to make sure that you have the understanding and the verbiage on all of these bills so that when we go during the summer to have these conversations, you can speak at a high level to them confidently and be able to get this bill passed. So those are the only things that I want to mention overall. And just again, your engagement is vital. You're going to hear that several times tonight. I can't stress it enough. You cannot just sit on this call tonight and absorb the information. You can't hold it all to yourself. No gatekeeping tonight. You've got to share that information with everybody. So please take this back to your colleagues. Put it in your groups that you're members of. Make sure that anyone that isn't on this call gets this information. And if they have questions, have them reach out to either the association or the coalition so that we can make sure we arm them with information. What we don't want is anyone going to lawmakers with disinformation or misinformation, because that will put us in a situation where we are not seen clearly or respected and ultimately could kill our bill. So that's all I wanted to share with regard to workforce. We're trying to get more and more people here. And if we continue on the path that we're on currently, we're not going to have enough people. We already don't have enough people to take care of the ones who are here. We're definitely not going to have enough people to take care of those who are continuing to move to South Carolina and call South Carolina home. So continue to share this information, and thank you all so much. That's all I have.
Can I just say a few words?
Yes,
And,
Stephanie.
and TK is right. This is not just an information session. This is an action, call to action. I mean, we're not going to get this bill unless all of us step up to the plate and call our legislators and do whatever we need to have done. We're going to post on the Coalition for Access website. Judy, can you send that link to Rosie so she can post it? And we're going to put fact sheets. We're going to put the verbiage that you need to be discussing with your legislators. We can even post some sample scripts if you plan to come to do testimony. But when we send out a call to action, call your legislator, call this legislator, do it. I mean, it takes all of us. That's how that bill got passed in 2018. That's how the bills have always been passed. I think Sharon Bond and Debbie Hopla and I have been around since dirt. And we've been doing this since what,
80 or 80.
88. I was pregnant with my second child, and he's now 35. So we want to get this bill passed, but this is a call to action, and we need everybody to do their part to call their legislator and say this, this, and this. And we will post those fact sheets and talking points on the Coalition for Access to Healthcare website for you all to download. And I also want to point out that if you want to find out what the legislature is doing, you can download an app on your phone. It says South Carolina Legislature, and that'll tell you when they're in session, when they're not in session, and you can even watch it and even go back to an archive and watch it. So if you want to look and find out what they're doing and talking about, you can access that information that way. It's a free app. So, okay, sorry.
That's okay. Thanks,
Thank
Stephanie.
you.
Kelly, do you have a update for NPI numbers?
Yes. So I know that most of us are probably on this APRN town hall or nurse practitioners, but there may be one or two, or hopefully one CNS, myself included, because this isn't just about nurse practitioners. It's about certified nurse midwives. It's about clinical nurse specialists and nurse practitioners, because this bill is about APRNs. And we all have a role to play in the healthcare of South Carolinians. So I wanted to be able to take a minute to talk about the role that South Carolina nurse practitioner or clinical nurse specialists play in the healthcare. And for those of you that maybe don't know what a clinical nurse specialist is, it is an advanced practice registered nurse role that is also a master's or doctoral prepared or postgraduate prepared nurse that also improves outcomes, either patient directly or at the organizational or system level. What's really important to note is that there are only 84 clinical nurse specialists left in the state. And as we just heard from TK, one of the reasons is pay, because we rank so low, about 48th on the pay scale for APRNs and registered nurses in this state, and people are moving elsewhere. But it also is because no one really understands the role, not the clinical nurse specialist, but health systems. But what you may not know is that clinical nurse specialists have been carrying historically mental health. A lot of clinical nurse specialists are experts in psychiatric care, and they were doing psych way before nurse practitioners were doing psych mental health. And they are also running heart failure clinics. They're running all kinds of clinics that have been established with their hospitals or even outpatient, and they're really important. And it's really important for clinical nurse specialists to be also included in this bill as they are. But what's also important is that clinical nurse specialists get their NPI number. Every certified nurse midwife and every NP has their NPI number. But do you realize that a clinical nurse specialist is not categorized as an independent APRN? They're grouped in with registered nurses. That is a problem. So the U.S. Bureau of Labor Statistics, Occupational Employment and Wage group does not count CNSs as an independent category of advanced practice nurse. So we need to make sure that we work together and we work as a group, as APRNs, to make sure that if you know it, CNS, you tell them about this bill, ask them if they have their NPI number, because their work isn't being quantified, it's not being counted. And the more people that APRNs that have their NPI number, the more that we are counted, we're being able to be billed, we're being counted in Medicare, and we can make a difference, because when we use our voice and when we band together, we're more powerful than when we're sitting home not doing anything. And like Dr. Burgess just said, this is a call to action, because if we don't step up, we don't share this information, we don't talk, we don't use our voice, we're not going to do anything. We're not going to get this bill anywhere. So if you want more information about CNSs, or you know a CNS that doesn't know how to proceed or is having problems with their role, tell them to call me or email me. My email is kboothele@gmail.com. Rosie can share it. Reach out to Rosie and we can talk about the CNS role. But it's really important that we push this bill forward, because there's a lot of people in this state that don't have access to health care. And there's nothing under an F, a failing grade, a worse failing grade. And we can definitely do something about that. Thanks.
Thanks, Kelly. Next up is a review of our paperwork that we have developed over the course of time. Stephanie and Kelly are going to talk about our talking points, disciplinary data, and all the other materials that we have developed.
So we've developed a ton of materials, and it's probably a little overwhelming. We're going to post those on the website, the coalition website, by Thursday. You can access all that information there by Thursday. But I do want to summarize what you really need to hone in when you speak with your legislators about this bill. And actually, Deb Hopla and Kelly Boothele developed this acronym. It's called RID, R-I-D. You all right, Debbie, if I go ahead and talk about it? Okay. R stands for remove these regulations that are impeding our ability to provide care to patients. And I believe they've already talked about that. I stands for improving patient outcomes. And again, the data shows that nurse practitioners, nurse midwives, and clin specs, when they are able to provide care, full care, without any restrictions, the data shows that patient outcomes are improved, especially with chronic disease management and women's health outcomes and maternity outcomes. And decreased cost, that's what D stands for. The cost means that we keep people out of the emergency room. We get less reimbursement, which is really significant to legislators and insurance payer systems. When we get 85% or 90% of what they would pay a physician, that's a cost savings to the system. It's not always what we want, but it's a way to demonstrate that what we provide is great care, but at less cost.
And I would just add, I'm going to jump in on the cost savings, because over time, when you're keeping your patient on a primary and preventative care regimen and they're keeping them out of the hospital, the overall costs to the state and to the insurance, somebody has to pay that unreimbursed care, and that's the taxpayers. So we may be getting reimbursed at a lower rate. However, the rest of the state is not absorbing those costs when we're saving patients from going to the ER for things that we can see on a routine basis. And we develop rapport with our patients, and they keep coming back, and we get them on a primary and preventative care schedule, and they know, don't go to the ER for that. Come in and be seen in our clinics, and get your primary prenatal care, and don't go to the ER for that kind of thing. And when you look at it over time, the money saved is very significant. So decreasing cost is a huge win for everyone. Not, like like she just said, it may not be what we want as far as reimbursement, but lives saved counts for something, and certainly cost over time and to the state really does matter.
And I'd like to just also second what Kelly said. The study that I quoted that showed improved outcomes at a cost savings, that cost saving wasn't in the decreased amount paid to the certified nurse midwife. The cost savings was in the lower C-section rate, less preterm birth, lower low birth weight babies, less NICU admissions. It's literally saving millions and millions of dollars in these huge giant bills in maternity care that we preterm babies are having health crises throughout their lifetime. We also know that women make the decisions in healthcare for most families. So when you get a woman during her pregnancy and she gets good holistic care, whole body care, whole family care, we see vaccination rates go up. We see the other people in their family getting the health care that they need. So it is imperative that the legislators understand that that cost savings isn't because we are paid less. That is just a tip of it. And in many instances, nurse midwives do get paid at 100% of the physician rate. Not always, but we do for Medicaid.
And one of the other things for maternal health, JAMA reported a recent article last year that women that have hypertension during pregnancy end up dying at a much, much earlier age. And that was a pretty comprehensive research article that was done by JAMA. So prevention is the key here in making sure that women have good outcomes for sure.
And I want to reiterate, the state is spending over $150 million a year. It's probably even higher on Medicaid beneficiaries who go to the emergency room for primary care. That is a stupid and very costly way to get primary care for a sore throat or an ear infection or a UTI, when those people could easily be seen in a nurse practitioner office.
I also wanted to say along the same lines on the FAQs that one of the things we did was a survey, and that survey demonstrated that most NPs that have their own practice are paying around $2,000 a month for that practice agreement. And if an MD can have 6 people on their license at $2,000 a month for 12 months, that's over $144,000. Always follow the money.
And actually, they can collaborate with more than 6. They just can't collaborate with more than 6 at any given time. So one of my physician collaborators has like 20, but that's because most of us are working part-time. So he only collaborates with 6 at any given time. But that's a huge cost to the system as well.
It should be.
So remember RID. Remove regulations, improve outcomes, and reduce cost or cost savings to the system. I'm sorry, Sharon.
No, the payment to physicians just to have your license should be illegal. It's just.
Well, I would agree.
That.
I would agree. We can have an offline discussion on that.
And unfortunately, most of the nurse practitioners who sign those do not know that that means that physician is now your employee. When you pay somebody, you're the employer, they're the employee.
That's right.
And what that means is you are legally responsible for their actions. That vicarious liability is flip-flop as soon as you pay them a check. And if you're ever involved, I do a lot of expert witness work. And if you're ever involved in a malpractice suit, one of the first things they'll ask is, do you pay your physician? And once you do, say yes, then you're responsible for any mistake they made.
In any practice setting, correct?
Correct.
Yeah.
Doesn't matter.
Doesn't matter if it's related to your practice. It's in any practice setting.
All right, thank you, everyone. The next part of us is going into testifying at hearings. We know that our bill should be coming up sometime this summer or fall, maybe getting some subcommittee hearings. And so we wanted to let y'all know what to expect when you go to a subcommittee or a committee hearing.
So do you want me to do that, or who do you want to do? And many of us on the call have testified at hearings, and if it's a subcommittee hearing, you just show up and sign up at the door. You may have to send a link ahead of time telling them the subcommittee that you'd like to testify. But I want to reiterate that if you plan to testify, you need to limit your remarks to 3 minutes max. You need to take a written copy of your remarks, because you may have to give it to the full committee. And there's usually 3 or 4 subcommittee members there who are hearing what you're having to say. And these are committee members made of senators and House members. You need to dress professionally. In other words, don't show up in blue jeans and a t-shirt that says "This bud's for you" or something like that. I'll never forget, I had a student go to a practice setting and show up like that. So you need to dress professionally, wear your lab coat, wear a name pin so people clearly know who you are and identifies your role.
I would just add, if you meet with a legislator that's not in session, like in your district, that you kind of follow the same principle, maybe not wear your lab coat, but definitely dress professionally and be professional. You know, you're visiting them in maybe their workspace or something, and just, you know, bring materials about the bill, be prepared to ask or to answer questions. And if they will ask a lot of questions, so be courteous and be prepared for a lot of questioning, and be prepared for maybe a different point of view, and keep your cool, and, you know, smile, tell about yourself, what you do, explain how the barriers affect your work, and just be kind and thank them for their time. And, you know, sometimes they'll call you back, sometimes they'll email you, hey, I have another question. But, you know, just be professional. I don't know that we can say it enough. How we act to legislators definitely leaves a mark. And we've heard a lot of stories of other professions not being professional, and we don't want to get that reputation. We want to make sure that if we don't agree on something, they don't leave thinking that, you know, we're unprofessional or we don't know what we're talking about. We are a very caring, compassionate, empathetic profession, and we can have a conversation with a legislator that maybe we don't agree with. And if we're anything, we're kind and empathetic.
And one of the things,
Give a business card as well, so that you know, they have a way to be sure to get back in touch with you.
That's a good
Yeah.
point. Good
and
point.
one of the things I was going to say, with that 3-minute speech that you have prepared, you need to be prepared because they can ask you as many questions as they want to.
Yeah.
So you can be up in front of them for a while answering questions. And again, keep your calm, because sometimes they will say things that are quite offensive, and you just simply have to smile and say, you know, on this point, you and I both can agree to disagree, and be as professional as possible, but go prepared with knowing what the law says, knowing what we're asking for, and do the big ask. That is the other part, is ask for their support. They want to know who you are. You know, it's important to know your legislators, but it's more important that they know who you are and the role that you play and what your focus is, and that is on the patients. Make sure your focus is always on the patient.
And the
Wear
hearings will be in
comfortable
Columbia.
shoes.
The hearings will be in Columbia at the State House, either in the Gressett Building or the Block Building, just so you know. And, you know, another thing, they may ask you a question that you don't know the answer, and you just have to simply and politely say, you know, I don't know the answer to that, but I will find it out for you, and I will get back to you in the next day or so with that answer. May I please have your email? Something like that. But like, don't make stuff up.
No.
That's a no-no.
Yeah.
No.
Never anything wrong with, I do not know, but I will find out and I will email you.
Right. I will get back to you. So we will have those hearings. So we've been told sometime this summer or in the fall. So we will send out a call to action, and we need you all to show up. We need all the APRNs as much as possible to show up. And when I'm talking about APRNs, we need our nurse midwives, our clin specs, and our nurse practitioners. This bill does not have anything to do with the nurse anesthetist. They have their own bill. And that was a strategic decision made on their part and our part.
And clients, if you have a client that can tell their story, that always is helpful. They want to hear from consumers.
Right, our patients. And I would even suggest that when you give your testimony, that you tell your own story and say, you know, let me share with you what happened in my practice when our physician moved away and we could not find a collaborator, blah, blah, blah. We had to close shop for 2 weeks. Patients had to go to the emergency room. This is how much it cost the county. We weren't able to give prenatal care. They had to go to the emergency room. I mean, there are lots of stories that we can all share. So that's what they want to hear.
All right, thank you, everybody. TK, we were gonna go back to you to talk about the key legislators. Are you still here?
TK, you're muted.
Can you all hear me?
We can
Can
hear
y'all
you.
hear me? I'm sorry. I just text Rosie and was like, I'm having connection issues. I can't hear them. What are they saying? What was the question? I apologize.
You were gonna speak on the key legislators, who we need to target for support. It was supposed to be you and Wanda, but I know Wanda's at the State House.
So Wanda is going to tell you, Wanda's going to say everybody, but right now, if you go onto, and I know Stephanie told you to go onto the South Carolina Legislature website. If you go on the website, look up our bill, you'll be able to see who are the sponsors of our bill, but also you'll be able to see who's co-sponsoring the bill. And then what you need to do is go to look at who's on committees. So Senator Danny Burton is one of those people. We need to get his support. He has some pushback. We need to, and I'm sorry, I'm trying to do this and look at other stuff at the same time so I can see what Wanda put on here. We also need to look at Senator, and forgive me, I apologize, ladies, that I am trying to do 2 things at once today, but that's just the way life just happens to be today.
TK,
Can y'all hear me?
can I interrupt?
Feel free.
So we need to target the Senate Medical Affairs Committee
Right.
and the
3M.
the 3M committee in the House, and we will post those senators and House members' names and contact information on the coalition website. But those are the people that we need to target for the hearings, especially the senators, because the Senate hearings will be this summer or next.
And Danny
fall.
Burden
Is
is
that right?
number 1 on that list.
Yeah,
Yes,
and
it'll be
Danny
this summer.
Burden.
He's number 1 because he's
Right.
the chair of medical affairs.
Right. And also Senator Alexander from the upstate. I think he's another one, but we will put that list out for you all, and we will have that on the coalition website by May the 8th. But those are the people that need to be met with, talked to, and persuaded to.
Thank you, Rosie. Rosie's actually dropping them in the chat to you right now.
Okay.
So you can have the committee
Cool.
members. And that's what I was getting ready to do. So thank you, Rosie.
Okay. Yeah, thank you, Rosie.
Also, if you find that your senator or
Thank
your
you.
House member is not on the bill, has not signed on as a co-signer, visit them. Call and make
Agreed.
an appointment and visit them and ask them to sponsor. Again, we're in the first year of a 2-year legislative session. For those of you who don't know, when a bill goes into place, you have 2 years or you have to start all over again. We want to make good access of this year and of next year. So please look at those names, look at those sponsors, look at the co-sponsors. If your local senator or representative is not on there, then make an appointment with them and go talk with them and share with them some of the talking points that we have on the Coalition for Access to Healthcare. Share with them your personal story, share with them and do the big ask for their support.
Good point.
All right, so I would like to open up our discussion up to questions. I think for the most part in our chat, the questions have all been answered. But if anybody has any questions that they would like to ask us, either about the full practice authority bill or about our legislators, please go ahead and just put in your questions into the chat. I don't.
One of the questions.
You take them off of, if you take people off of mute, it'd be good too.
And one of the things that was asked in the chat was about stimulants, Schedule II stimulants. You can write for Schedule II stimulants, and you can write for a 30-day supply. So that is the current law that is in the upcoming law that we've asked for. And so that has not changed.
We just answering, or are we typing the answer, or are we just answering out loud?
We can just answer out loud.
Because someone is asked new here, so I'd like a link where I can look up if our senator is sponsoring or not. So I'll go ahead and answer. So we already dropped the links to the bills, and when you go into the bill, you can see the history and who is already currently sponsoring, and that will let you know if your local senator or representative is on that bill as a sponsor.
And if you're new to South Carolina, or you're new and looking up legislation, go to scstatehouse.gov. And on that front page, it has a quick search, and put in S45 and it'll bring it right up. In the very top of it, you'll have your sponsors and a short synopsis of what the bill is about. And then you'll have all of the information about the bill in language, and I call it lawyer language, but there's a synopsis at the very top with the sponsors and co-sponsors. So scstatehouse.gov.
And somebody asked a question about social media and posting with the newspaper, SCE, and TV. Yes, part of our coalition, we do have a social media expert, and she is working on that fast and furious to make sure that things are posted on Facebook. Deb and I have Twitter accounts, and I only use it for political reasons. And we are working.
It's now called X.
Yeah. Yeah, now
And
called X. I still call it Twitter.
And we have also written several articles to speak specifically on APRN roles, full practice authority, lack of access to healthcare. So over the last several years, we've written various articles. We've also published work on our survey that we did. Goodness, I don't even know how many years ago. 2 years ago, Judy, however long that was.
Last year.
Yeah, so we've written work on that. All of us use our social media, and we're also all of us are in different portions of the state and affiliated or loosely affiliated with various APRNs in our region, and share all the information where we are locally, and also are trying to share that information. So we are definitely not keeping quiet.
One of the things that was asked was about how we arrived at the 2,000 hours for full practice authority. And I can tell you that there was a lot of research done on this about what was required in other states. Some states require as many as over 4,000 hours. And so we came to a consensus that 2,000 hours was reasonable. That's a year of practice under a collaborative agreement. And we feel like that, it's always good to be able to have a resource for that first year. I don't know about anybody else, but for the first 6 months, every day I prayed, God, please don't let me kill somebody. Let me know what I'm supposed to know. And, it is looking at nationwide what is being required for states to get full practice authority. And 2,000 hours was typically a low end of the average.
Plus, the Hospital Association had some concerns about new graduates. And as Deb said, really no one's a finished product when they finish school. Medical school, pharmacy school, engineering, whatever. People need a mentorship. And so that's how we arrived at the 2,000 hours, because that's a working full-time for 1 year. And that seemed to satisfy a lot of groups who were concerned about new graduates coming out of the chute and then opening up a practice. The Hospital Association was also satisfied. I do want to reiterate that our media person is also working on getting interviews and hosting press conferences. But if anybody in the organization or tonight on the webinar has a contact with various newspapers, news outlets, please let us know. You can put that in the chat, or you can let myself know, Judy Zink, Kelly, Leslie, Debbie Hopla, any of us, Rosie, whatever, let us know and we will make contact with that person to get an article.
And I would like to say that there are two Facebook sites. One is South Carolina Nurse Practitioners, and the other one is the Upstate Nurse Practitioner Association. Upstate Nurse Practitioner Association has two Facebook pages, but you want to go to the one where you actually have to join. And that one does not allow anyone else but nurse practitioners to join it. So it's a private group. You can ask what questions you want. You can see when the Upstate group has meetings. It's a very good group to join just to get information.
And one other thing, there was a question about the Hospital Association support. They have publicly said they are supporting it. They still are looking at certain aspects of the bill, but they particularly were pleased that we came to a consensus of the 2,000 hours.
And I was just going to add that the National Council of State Boards of Nursing, their threshold, I think, was 2,080 hours. So we just came under theirs. And there, as Deb Hopla said, there are some that are way over 2,000, somewhere between 2,000 and 3,000 for some of the states that do have a threshold. So that's how we kind of settled on our number.
Right. Any questions about the aspects of the bill? Like, I mean, anything, what can we answer? One of the documents that we can post are just some key aspects or key, a summary of the bill, so that when people ask you about it, whether it's a legislator or a physician or whoever, you'll have some talking points. It'll be a one-pager summary of the bill, what it does and what it doesn't do. So somebody asked a question about specific legislative day. That will be next year, February the 26th. Good question. Put it on your calendar, February the 26th from 8 to 12 at the State House. And we will meet in the Blatt Building, BLATT Building, first floor conference room.
One of the questions that was just asked was, if they make a recommendation for 3,000 hours, will the bill have to start all over again? There can always be edits to a bill when a bill is presented. But again, we think 2,000 hours is a good number, and we hope that they agree, but we shall see.
But it is a negotiation point. So that's a good question.
All right, everybody. It doesn't seem like there are any more questions for tonight, so I'd like to give y'all back your other 37 minutes. And I look forward to seeing everybody at the State House next February and at our subcommittee and committee meetings.
February 26th.
Thank you for our panels. Thank you for our panelists tonight.
Thank you,
all
everybody.
for your participation.
Thanks, everybody. We appreciate you all being here.
Thank
Please
you.
share everything.
That's right.
And show up.
Right.